الأول دكتور فادي القيسي بيحكي لنا عن approach to calcified lesions. دكتور فادي مش بحاجة لتعريف، وأهلا وسهلا في الدكتور فادي. تفضل.
بسم الله الرحمن الرحيم. السلام عليكم جميعا، صباح الخير. My talk is about how to approach calcified lesions. I'm very happy إنه يكون معنا على البانel a surgeon, because if you are going to approach calcified lesions, you need to have a very close surgical friend. I have no disclosures. So what we are going to be talking about. احنا حكينا في الموضوع هذا قبل سنة أو سنتين، واليوم إن شاء الله تعالى we are just going to update the talk. هنحكي أول شيء عن the scope of the problem and the challenges in decision making. هنحكي how to identify and evaluate calcified lesions and how to manage, and we are going to end up with some challenges in Jordan. بداية مشكلة calcified lesions, they are coming more and more frequent. We have advanced age population and more comorbidities in diabetes, chronic kidney disease, hypertension, smoking, and family history of chronic heart disease. Calcified lesions, why they are challenging, why they are having higher risk. First of all, they are lower procedural success. It's difficult to deliver equipment, as shown in the first video. You can see how it is very difficult to turn a stent around the angle of the left circumflex artery. It's difficult to expand and break the calcium, and as you see في الصورة الموجودة laser pointer, there we go. As you can see here, this is a stent that was not properly expanded in spite of post-dilatation, and there is multiple complications of rupture of the artery and dissection of the artery if you are pushing a little bit too hard. In addition to the late complications under expanded or calcified lesions, we have higher tendency for stent thrombosis and restenosis. And there are special challenges in decision making. كثير أمراض we are encountering a lesion and we can say, should I try it or not? Is it that calcified? خليني أجرب، بلكن زبطت وبلكن قدرنا to crack the lesions. المريض already على الطاولة، already دفع باكج المستشفى، أشيله وأحطه مرة تانية. طب إذا قلت له إنه ما زبطت معي، حدا تاني حيجرب وتزبط معاه، وشو حتطلع صورتي إنه أنا قلت له مش ظابطة وطلعت لا بتزبط. and إذا جربت وما نفعت معي، شو بدي أطلع أحكي للعيلة؟ حاولنا وفتحنا وحطينا أدوات وبيتناه في الآي سي يو وما زبطت معي. القضية الثانية، طب كيف بدي أعرف أنا حتزبط معي ولا مش حتزبط معي؟ Can I do it or not do it? And if I try it, what happens if I leave under expanded stent? يعني this is going to be a very challenging for everybody. ففي عنا إحنا methods to try your calcified lesions, and then you can estimate your success of try with the traditional methods versus the need of advanced methods. من ضمنها previous CT scans. طبعا احنا صرنا اكثر واكثر نستخدم CT angiograms. هذا بيعطيك فكره جميله جدا عن heavily of the calcifications, the score of the calcium. القضيه الثانيه فلوروسكوب زي ما احنا شايفين هون، تقدر انت you can estimate especially with the experienced eyes انه هذا how calcified it is، ولكن لها طبعا limitations. والقضيه الاخيره وهي الاهم وهي الستاندرد اوف كير اللي هو intravascular imaging بانواعه. إذا نحكي شوي عن الفلوروسكوبي. الفلوروسكوبي has limitations لأنه الفلوروسكوبي does not evaluate the circumferentials outside the walls, inside the walls, how circumferential and how extensive the lesion is. Compared to IVUS, sensitivity is only 50%, specificity is 95%, and it cannot differentiate subtypes of coronary calcifications: superficial versus deep, thickness, calcified nodules, arc of calcium. These are two of my patients, actual patients. The first one is the left main. Looking at the fluoroscopy and comparing the colors of the left main with the native, with the LED and the left circle, I thought, this is heavily calcified left main. This is going to be a nightmare. I need to have a Rota. Then I did the calcium, the IVUS, and I see the calcium was only on one side and not circumferential, and I did this case without any plaque modification. On the other hand, you see this artery, and you see, okay, it's a small calcium, small piece, I can crack it with the balloon. خلينا نجربها. بس لما عملت الIVUS could not cross the lesion. It was almost 360 calcium, very extensive, very harsh. I had to use Rota to clean the artery properly. فالintravascular imaging الحلو فيه يعطينا extent of the calcium, phenotype, and it guides us to use the modifications. And by guidelines, it's class 2A for plaque evaluation. We have to remember the recent study about the value of the IVUS with the left main. There is a difference between using the IVUS for sizing and optimization of results, which is the traditional use. But more and more recently, we are talking about the IVUS for plaque understanding, plaque characterization, which is totally different usage of the IVUS. طبعا IVUS compared to pathology is very accurate one. There are two different IVUS available in Jordan. في عنا Boston Scientific إلهم ميزاتهم وفي عنا الفولكانو إله ميزاته. If you get used to one of them, just whatever you like, and it's important to have availability of both of them. كل واحد إله ميزاته إله سيئاته. الIVUS بيبين الكالسيوم bright echo shadowing. It has you cannot see beyond the calcium. بيقدر يفرجينا الارك, length, but not the thickness. The calcium, the ultrasound cannot penetrate calcium. It's good for ostial left main, ostial RCA, and it does not need contrast. So this is very good. You can do as many IVUS as you want during the case. OCT, which is not available in Jordan, optical coherence tomography, it shows us the attenuation, low black scatter, low attenuation, like this one. It can measure the arc, can measure the length, but it can also measure the thickness of the calcium because this can penetrate beyond the calcium. It cannot be used for ostial left main or ostial RCA because it needs contrast. You have to inject contrast to clear the artery from any blood so you can see the calcium properly. And it has superb resolution. What are we looking for when we do intravascular imaging? So I chose, قررت بدي أعمل intravascular imaging. قررت الوسيلة تاعتي IVUS ولا OCT. بدي أتفرج على الارك, الثيكنس واللينث, وإذا في عندي أي نوديولز. وإذا في عندي الارتري أقل من 3.5 ملم بكون هدول مزعجين أكثر. طبعا في عندنا بوينت سيستم بدنا ندور عليهم زي ما حكينا. is it 360 زي ما حكينا. إذا في عندي نوديولز, إذا في عندنا less than 360, what's the length of the imaging اللي في الليجن اللي عندنا. في عندنا scoring system, and as you see we are going to cover the IVUS score rather than the OCT score. إذا عندك circumferential calcium 360 تعطيه 1 point. إذا عندك less than 360 ولكن طوله 5 ملم تعطيه 1 point. الليجن less than 3.5 ملم تعطيه 1 point. Calcified nodule 1 point. 2 points and more, this is an indication to use IVUS. But what do I need to achieve calcified arteries? I have to decrease the calcium burden, shave off. يعني بدنا نسنفر الارتري ونشيل الكالسيوم ونحط الصخر. الشغله الثانيه I need to disrupt the calcium. بدي اكسر الكالسيوم بحيث لما يدخل البالون يكمل عليه. بدي احط شق في الصخره حتى اقدر اكسرها بالبالون تاعي. شو التولز تاعونا؟ التولز تاعونا في عندنا الكومبلاينت نون كومبلاينت بالونز، في عندنا سبيشال بالونز، في عندنا الاثوريكتومي ديفايسز، وفي عندنا الانترافاسكولار لايثوتريبسي. نحكي عنهم واحد واحد. اليوجوال كومبلاينت ونون كومبلاينت بالونز they are available low cost، ما بدهم اي سبيشال سكيلز، هذول موجودين في كل مختبر. مشكلتهم they cannot expand more than mild calcium. اذا في عندك heavy calcium they cannot work properly. القضيه الثانيه الووتر ميلون سيد، او بمعنى اخر بمزلط البالون بيطلع من المكان ما بضله قاعد في محله. الشغله الثالثه المهمه جدا اللي هي eccentric expansion. This is very important to look for it، لانه في عندك انت الاكسنتريك expansion بتشوف البالون بتفكروا انه فتح على الاخر، ولكنه يفتح على حساب الادفنتيشيا وليس على حساب اللومن نفسه، فبالتالي ممكن تريسك perforation ودايسكشن. الهاي بريشر بالونز they are available، كل لاب عنده هاي بريشر بالونز، عندهم ميديوم كوست ولكن ما بيحتاجوا اي سبيشال سكيلز. مشكلتهم they are bulky because they have thick walls فالدليفري تاعتهم بتكون صعبه لانه اذا كان كالسيفايد حيكون صعب تو ديليفر ولسه في عندك ريسك اوف بيرفوريشن دايسكشن لانك انت تعتمد على القوه في كسر هذا not controlled dilatation. بعدين بنيجي للكاتنج بالونز والسكورينج بالونز again they are available medium cost no special skills والحلو فيهم انهم more predictable dissection they have small wires و small blades اللي بيدخلوا جوا الكالسيوم وبيمسكوا في الكالسيوم فما البالون does not watermelon ما بيمصلط ولكن برضه مشكلتهم الدليفري تاعتهم لانه they are bulky وما بيقللوا لك الكالسيوم لود ما بيشيلوا شيء من الكالسيوم. الاداه الثالثه اللي هي روتيشنال اثيركتومي عندنا فيري هاي سكسس ريت فيها اتس اكشوال كالسيوم موديفيكيشنز مشكلتها not always available بدك بريفيس ارينجمنت ابو رعد جيب لي الجهاز بكره عندنا كالسيوم جيب لي البيرز سايزز جيب الجهاز وهاي كلياته هاي كوست ومعظم التامينات ما بيغطوها والحمد لله تعالى. It needs special skills how to manage الروتا وبدك كمان لها complications very bad complications once you see روتا بتحلف مش هستخدمه مره ثانيه no reflow dissection perforation or entrapment of the balloon. هذه واحده من الحالات اللي فرجيناها قبل شوي لما عملنا النوديول وكان الكالسيوم on the right side you can see how heavy the calcium it is استخدمت لها rotational atherectomies وبعديها قدرنا نعطي الحمد لله نتيجه very full expansion والمريض لسه بيتابعنا صار له 3 سنين والامور no restenosis. You can see here we did for him previous TAVI في اثناء التافي عملت له ultrasound وقلت له listen this is heavily calcified I'm not going to touch it with the balloon let's reschedule it for a rotational atherectomy. حكينا عن no reflow this is one of the patients that I had a no reflow وهذيك اللحظات الواحد بيقعد يفكر مليون مره ليش اخترت الطب وليش دخلت التخصص كله على بعضه وبعديها ولكن المريضه الحمد لله she survived it she did very well ولساتها بتراجعنا بعد سنوات وكانت النتيجه النهائيه ممتازه والحمد لله. Orbital atherectomy they have very high success rate is again actual calcium modifications they are not available yet in Jordan بس في جماعه بيحاولوا يجيبوه it has a high cost same thing it needs previous preparations it needs special skills ونفس الشيء عندهم high complications when no reflow dissection perforation. Laser atherectomy high success rate it's actual plaque modifications it works with any Holt wire ما بده special wire زي الثانيين not available in Jordan high cost as well. وفي عندنا الجميل جدا 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 intravascular lithotripsy هذا اختراع رائع جدا high success rate it has actual calcium modifications it doesn't need any special skills just plug in deliver and it cracks the calcium. Unfortunately again not always available بيعتمد قديش أزمة السيارات عبين ما يجي لك من يروح على المخزن يجيبه ويرجي لك على المستشفى it has high cost very high cost بس الحلو فيه if you can treat more than one artery you can use the same balloon. It has difficult to deliver. You have to make sure that you are able to deliver this bulky balloon. And the patient, this is important, the patient needs to tolerate the 1 minute inflation and cutting of the flow. So if you are working on the last remaining arteries, خطر يعني. وياما صار عندنا hypotension وإسكيميا أثناء inflation of the balloon. This is one of the cases that I did in Jordan. You can see here, I did the same balloon. لفيت عليهم على LED, على diagonal, على left circ, شوية inflation هون شوية. But it was very cost effective. This is another case of lithotripsy on OCT. Obviously I did this in the US. You can see here how deep the calcium and you can see here the cracks. These are the cracks that we generated in the calcium by the lithotripsy. Then I was able to put the stent with full expansion. Those dots are the stent dots. طبعا في algorithm. You can cross the lesion, you cannot cross the lesion, what to do, how to approach all of these things. I will skip this for the sake of time. And you can choose which one is going to be best. Obviously, this algorithm is very useful, but with experience and with time, with the look of the lesion, you will do that algorithm in your brain and you will know which device that you think is best for this patient. Local challenges. We have local challenges في جوردن طبعا. رقم 1 challenge cost. كل واحد من هدول بكلف له مبلغ وقدره بدك تضيفه للبيشنت البيشنت بتطلع عليك ويحكي لك ان شاء الله دكتور خليني افكر برجع لك. But this is very challenging. But that's why we rely on our partners, our colleagues في الخدمات في الصحة يستخدموهم أكثر lower the cost في جنرال في الجوردن. قضية ثانية availability. usually بدك تحضر لإلهم ليجي لك المندوب أو يجيك الجهاز ويحضروا لك إياه وتحضر البيشنت تفهموا على الكومبليكيشنز. فusually they are separate procedures. طبعا في أمريكا شغلة كتير حلوة، افتحوا الروتا، افتح اللاثوتريبسي and you just need to make a medical decision not a financial decision as well. آخر إشي بدك البيشنت يفهموا what tool you are using, what complications is going to be expected. What does it mean to use Rota? شو يعني أبي أدخل أعمل روتا وممكن يصير في معي emergent bypass surgery وأنادي السيرجن فورا. those are local challenges that we need to understand. And at the end, thank you. Perfect time.
شكرا دكتور فادي لالتزامك بالوقت والأسئلة لنهاية الجلسة. تفضل دكتور سعد.
صباح الخير جميعا. المحاضرة الثانية لزميلنا وصديقنا الدكتور رائد العوايشة Stubborn Nodular Calcium Intervention. يعني I'm eager to see what Dr. Raed will do with stubborn lesions.
Thank you very much, Dr. Saad. Thank you for all the attendees. طبعا we should know that calcified lesion, Dr. Fadi, I think he elaborated very well that it is one of the most important enemies that we have inside the cath lab. And when we come to the calcium, I really wished from Dr. Fadi to show when we have the concentric calcium, when we have the eccentric calcium, when we have nodular calcium, and what to do for each one of them. Maybe this is very advanced, but I think this is the way actually to deal inside the cath lab, that really you need to know what calcium you are dealing with and which tools that you have in your hands and how to deal with it. It is very good that to have a luxurious cath lab with all the tools that you want, but sometimes you don't have it and sometimes they don't work. And one of the examples is this case. My patient is a 67-year-old, he's a heavy smoker, COPD, dyslipidemia, all these factors that you know, and he had ischemic heart disease. He had many times coronary angio and many PCIs in the past, but for the last 4 months he had recurrent admissions to the hospital with pulmonary edema, and he had the chance to have a cath in one hospital where they have Rota, and they did for that nodular calcium rotablation, and it failed. And this is the picture after I received the patient. This patient had this obvious nodular calcium at the ostium of the LAD, and this lesion has been tried with rotablation, but it failed. So, what to do? You have Rota and failed for this nodular calcium. I think it should replay. Doesn't replay. Okay, that's good. Thank you. So, any ideas? I think for the sake of time, and we are in rush, so here we use the tools or the techniques actually we use in CTO. CTO techniques as CTO operators, what to do for nodular calcium. Actually, you have the approach of extra plaque approach. What do we mean by that? Is to go behind the calcium and to crush that calcium and to overcome this problem. Why we have problem with nodular calcium? Because when you go with Rota, you know the wire bias and the wire bias problem. And also you cannot do the shockwave, because shockwave you need concentric calcium. You need the ultrasonic effect to hit and to hit from both sides. If it did not hit from both sides, it would not work. So the extra plaque approach is the way to go with the extra plaque external crush. So to do that, you need to have a good support. And to have a good support, you have many ways. Either to use a good access, the bigger catheters like 7 French and 8 French, and also to go after that with the extension guiding catheter, and to use the penetration wires where you can penetrate the calcium. So these are one of the examples, the shape of the catheter and these things. This is the non-compliant balloon actually did nothing, as you can see here. And OBN balloon, this is OBN balloon as mentioned by Dr. Fadi, it ruptured. This nodular calcium is very sharp actually, and it caused rupture of the OBN. Luckily that we didn't have any complication, so now we go for extra black approach. We have a wire there in the LED, and this black wire is Miracle 12 actually, with a shape to stop the calcium from its body or subintimal and to go behind the calcium. And you need to do that. Maybe you will be able to do it by the wire, but you cannot follow it with any balloon. So you go with a small size balloon and to use the distal anchor technique. I have the chance that I have a stent before, and to go with the extension guide catheter, and this is the technique actually to fix the external guide catheter or the extension guide catheter by inflating balloon in the extension guide catheter to establish it very well, so you can punctate and you can go through the extension guide catheter and you go with the balloon and insert it inside, and to go inside the calcium, insert it inside it and inflate it inside it. You can see there the distal, I'm not quite sure if I can see, I will show it to you. I have pointer, laser pointer. How many? I have 2 minutes more. So, it did, I think. Okay. You can see here you have a balloon here, and this is what I inflate the balloon here to fix the Miracle 12 and fixing it there. So I'd be able to go with the other balloon here and inside the calcium and crush it from inside. And after that, as you see here, and after that we go with seesaw technique. Seesaw technique actually is to go and to inflate from outside and from inside that calcium body. And after that, after you modify or marinate that calcium, I go with the 2 balloons together, inflation, and the crushing that calcium. I'll be able now to go with the stent, inflate the stent there, open it there. Here we crushed it, 2 balloons together at the same time, one inside the body of the calcium and one in the true lumen. And after crushing, go with the stent, stent it very well, and this is the result. And of course, spot because it's left main. So this is the final result for this nodular calcium. This is the way how CTO operators actually deal with the external. We have many cases. In the next session, we will show how to go with the ADR and extra plaque approach. So this is the conclusion of my case. Nodular calcium actually is one of the most difficult enemies inside the cath lab. Most of the available tools at meantime, sometimes they don't work, and in this way you can use this extra plaque approach as a technique to overcome this problem. Thank you.
Thank you very much, Dr. Raed, for the enlightening case. Questions at the end of the session. Dr. Yusuf, you might Basha, if you will.
دكتور متحدثنا الثالث معروف لدينا ولديكم. تفضل دكتور فادي.
دكتور محمود حاب يتخلص مني بسرعة، فحط لي كل شيء بسرعة وأروح.
7 دقائق.
Very impressive, Dr. Raed, ما شاء الله. So another calcified, another challenging case. So I see your case and I raise you my case. So I have a double Rota case, and as the American said, drill baby drill. So what did we do? I have no disclosures. This is a 73-year-old lady. She has been having recurrent episodes of chest pains for many years. They are at rest, associated with shortness of breath, 2 to 3 times a day, using sublingual nitroglycerin. And you can see on the right side the list of the medications that she has been using all the time, and multiple anti-anginal medications to control her symptoms. But recently, the pain started to worsen for the last 3 days that she had to be admitted to the hospital. Sublingual nitro is not working anymore. And she has been very compliant with her medications. She is no case of hypertension. She had bypass surgery in 2018, and we are talking about this case encounter in September 2025. So we are talking about 7 years. She had all venous grafts to the LOD, OM, and the RCA, the usual suspects, and she is known case of carotid artery stenosis. Those are her list of medications with maximal tolerated medications and anti-anginal medications. Those are her lab tests. with the creatinine normal and slightly elevated high sensitivity troponins. You can appreciate in her ECG the ischemic changes. Appreciate we'll come back to this later. You can see the T-wave inversions indicating ongoing ischemia. This is her chest X-ray, and you can appreciate pulmonary edema and fluid overload. So she had a previous workup. During this previous year, she has seen a few doctors and she has been a lot of workup. Remember, our encounter is September 2025. So she had CT coronary in February 2024 that showed heavily calcified native arteries, left main LAD, left circ RCA, and 2 venous grafts that that were occluded, and a tight lesion of the last remaining venous graft to the OM. No cath were offered for her, according to the patient, because it's a very high risk. She did have pharmacological nuclear stresses in November 2024, and you can see on the right side that the interpretation of it, that this is infarction. It's a fixed defect in the LAD, but the EF was reported to be 58%. And for people who are not used to these pictures, so the bright color means blood is getting there, darker, there's mean no blood. And you can see here that the anterior wall is not evident on both, indicating infarction or suggesting. But the echocardiogram in April 2025, a few months ago, showed EF 55 to 60% with severe mitral valve regurgitation. We happen to have the echo images here. And you can appreciate that the inferior wall is moving, the anterior wall is moving, and you can see here that the anterolateral wall is moving as well, and there's severe mitral valve regurgitation, which is most likely ischemic. Again, you can see the anterior wall is hypokinetic, but it's not akinetic, it's not thinned. In addition to that, this is the anterior septal wall in the 3-chamber views, and it is still moving as well as the inferior wall. So, back to our September. So my impression was, this is the echo, it is viable. So to consider this is a dead muscle and that we don't need to revascularization is a wrong conclusion, because remember, the nuclear stress test was ischemia and not viability test. So the actual infarction, I believe personally, that was ongoing ischemia, even at rest. That's why the blood was not getting there, but the muscle is still alive. After long discussion with the patient and convinced them why we are going to change the decision about doing a cath this time, they convinced and we decided to do the cath. And this is her cath. Again, you can see this is total occlusion of the left main, of the left circ, and severe stenosis of the left main and very severe stenosis of the LAT. This is again the picture. You can see the calcium here. You don't need intravascular imaging. And you can see also the blockages in the mid and the distal, which is most likely the anastomosis site of the previous graft. And you can see here the very tight lesion. This is the RCA, and you can see her tortuosity in the mid RCA with heavily calcified arteries. I was lucky here to have the previous CT scan. Unfortunately, I was not able to share it with you, and that can show you the severe calcifications in that area. That was confirmed with the fluoroscopy. This is the last remaining graft, and you can see the tight lesion in that venous graft. So, I stopped here, I took her off the table, and we had a decision discussed with the patient, with the family. How to treat, which order, and what's the best surviving artery, and what's to do with these approaches. My approach usually with these complex cases, leave the best artery the last. And in my belief, that was the venous graft to the OM. That was the artery that was عم بصرف على القلب في هذه الوقت with the highest risk of complication. If I occlude that artery, the patient is done on the table. The artery that contributes the least, I thought it was the left main and the LAD. Yet, if I fix that, it will give me the biggest delta of benefit. So, this was my plan. Do the left main first. Obviously, it's the worst one with the largest benefit. Do the RCA second. Why the RCA second? Because it's better than the left main, and it's the highest risk for perforation because of the tortuosity. If I deal with the perforation, I need at least to have a left main to survive the patient for the next few minutes while I fix the perforation. And the SVG to the OM, because it's the highest risk for no reflow, and if that is gone, the patient is dead. So, This was my plan. I started to execute Rota ablation. There was very difficulty to cross that Rota ablation. And at the end here, you can see even with the Rota ablation, I had difficulty advancing stents through the difficult arches. But I was able to advance the stents. I started distally. I put 2 overlapping stents for the LED, and that was the results. The patient tolerated well. The case was smooth. So I told the patient, are you ready for the next one? Don't forget the cost of the Rota. So he said, yes, I'm ready to. I said, okay, let's move on. So I moved to the RCA. I started to Rota. The RCA I did with a pacemaker. And there was some difficulty with concerns about the perforation, but it went smooth. And I did have difficulty in delivering. I just wanted to share this technique quickly. When you have difficulty advancing the Rota of the balloon, I go with the all-in technique, I call it that way. So I inflate the balloon, you approach the guide liner very close, deflate the balloon, and engulf the guide liner to the balloon to advance it further. And this is the final results with 2 overlapping stents. The case went very smooth. And I said to the patient, do you feel comfortable? She said, yeah. I said, okay, let's do the 3rd one as well. So we moved on to the SVG, which is the easiest step, obviously, here. This is direct stenting. It's no-brainer. It's the easiest one to do. It takes 5 minutes extra, post-dilated, and we are done with all 3 arteries. We did 3 overlapping stents in the LOD, 2 overlapping stents in the RCA, and 1 stent in the venous graft that was post-dilated to 5.5 balloon with very good results. 3-month follow-up. The patient feels much better. She's been improved. List of medications, you can appreciate the disappearance of the anti-anginal medications, and hair labs are stable, creatinine is stable, cholesterol is stable, and you can see this ECG, normalization of the T-wave inversions. Remember the previous September ECG with the T-wave inversions? We are still waiting for the 6-month follow-up to update you about the mitral valve regurgitation, which I believe was ischemic. Final messages, we have always to weigh the risk and the benefit for the patient, and engagement with the family, understand the risk, and obviously always carefully planning execution of these difficult cases. Appreciate your attention. Thank you very much.
شكرا دكتور فادي. Last speaker دكتور سعد قدم. تفضل.
Thank you, Basha. We would like to welcome Dr. Younis Daralammouri from Palestine to talk about the nearly closed left main, PCI for a severely calcified.
هو آخر واحد بين مش بحكي سمعني
دكتور يونس.
سمعيني السلام عليكم صباح الخير الجميع. احنا ما في عندنا طياره دكتور محمود انه تلتغى اخر شيء، بس رغم هيك الطريق كانت صعبه، واحنا سعيدين ان نكون معكم في الاردن هان بلدنا الثاني ان شاء الله، واحنا بنتشرف ان نكون هان. حتكلم على I will discuss a case of severely calcified subtotal occlusion of the distal left main in a patient with severely reduced ejection fraction. The patient was a 71-year-old female with a history of diabetes mellitus and paroxysmal atrial fibrillation. She also has hepatitis C complicated with liver cirrhosis. She presented with chest pain on mild exertion for a few days. The ECG showed mild ischemic changes include ST depression. The lab test revealed thrombocytopenia with a platelet count of 83,000 and elevated troponin. The echocardiography showed a severely reduced systolic pump function with an ejection fraction of 25 to 30%. The diagnostic angiography demonstrated a true distal left main lesion, Medina 111, with severe calcification. The right coronary artery was dominant without significant stenosis. The STS score was 22. The STS score estimated a surgical risk of mortality approximately of 6% with a combined mortality and morbidity risk of 14%. This case was discussed in heart team or with heart team. However, due to severely reduced ejection fraction and underlying liver cirrhosis, surgical risk was considered high, and therefore the patient was referred for high-risk PCI. Now, how should we approach this patient? What do you think? What do you think? I have, so okay. Have 3 minutes? Okay. 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 According to SC guidelines recommendation, if the syntax score between or equal 22, PCI may be considered if the complete revascularization achievable. If the syntax score between 23 to 32, PCI has a class 2A indication. However, CABG is the preferred intervention mode. This slide compares AHA guidelines and AC guidelines. An important update is that imaging now has a class 1A indication for left main PCI. Now, what is the optimal stent strategy for left main? The DECA crush demonstrated that DECA crush technique significantly reduced target lesion failure by 46% at 1 year and 47% at 3 years. However, ABC main study didn't show any clear benefit of upfront two-stent strategy. According to EC guidelines, the EC guidelines recommended provisional stenting as a default strategy for left main. Upfront two-stent strategy may be considered in selected cases when there's a long CX lesion, high risk of compromise or difficult access. Our procedure plan including femoral access, mechanical circulatory support with intra-aortic pump, rotational atherectomy, followed by IVAS guided DECA crush. We began the intervention by inserting an intra-aortic pump. A 7 French guide catheter was used, LED was wired, and given the severe calcification in the left main and LED, we performed rotational atherectomy for left main and LED. The IVAS confirmed the extensive calcification in the distal left main and proximal LED with calcium arc more than 27 degrees. In contrast, the circumflex has less calcification, so we didn't perform rotational atherectomy for LCX. We dilated the circumflex, implanted a stent with minimal protrusion in the left main, crushed the stent, and performed kissing, fist kissing. A second stent was placed from left main to LED, then second kissing, POTS, and this is the final result, angiographic final result. The importance of IVAS is well established. In the main compare study, IVAS guided BCI was associated with lower mortality, and reduced the rate of death, myocardial infarction, and stroke. IVAS allows precise assessment of minimal stent area which correlate with outcomes. The cut-off value for LCX 5 mm, for LED 6 mm, for left main 8 mm. Post-procedural IVAS demonstrated an excellent result with a minimal stent area of 14 mm for left main, 9 mm for circumflex, and 11 mm, 9 mm for LED and 11 mm for LCX. In conclusion, rotational atherectomy for left main and LED is feasible and safe even in the presence of subtotal occlusion of circumflex. In patients with left main disease, a reduced ejection fraction, prophylactic circulatory support may be considered. Intravascular image is essential to guide PCI, assess the final result, and optimize outcomes. Achieving an adequate minimal stent area is one of the most important factors for good outcomes after left main PCI. Thanks.
شكرا دكتور يونس الله يعطيك العافية excellent talk. Now we are already running very late time wise. Keep only 10 minutes for discussion. The floor is open. نطلب من كل سائل يعرف على نفسه والسؤال موجه لمين السبيكر. Floor is open. لازم panelist تفضل.
Yes. Thank you for the speakers and the chairman. My question for Dr. Fadi. In congenital patients, you are seeing a calcification as well, especially post-coarctation, post-coarctation stenting or surgery. We see it at the pulmonary valve for pulmonary valve replacement or repair. My question is simple, in fact. Do we have preventive measures to prevent this calcification or to prevent the progression of calcification?
That's a very, very excellent question. I get asked this every day in the clinic. How can we prevent progression of calcified valves, calcified arteries? Right now, our question is the same traditional. العب رياضة، وقف دخان، خذ أدويتك، وسيطر على الدخان، سيطر على الضغط، وسيطر على الكوليسترول، lower your risk factors. This is the best we can. And right now, it's the evolution of the calcium control for very aggressive calcium. The lower, the better. Those are. I am aware of many of you are aware of this trial for the aortic valve stenosis, that there is a medication to slow down. I apologize, I don't remember the name. If anybody بتذكر الاسم تاع الدواء أو الtrial for the aortic valve stenosis, the medication is on the horizon, but it's still not available commercially. Please correct me. But the answer for that, unfortunately, we don't have things beyond the limited tools we have. Calcium is stronger than all of us.
I have a question. My question is for Dr. Fadi. I mean, I know we probably have fellows here. Any hints on the angiogram to maybe assess the degree of calcium? Is it a case that you should jump in, or is it a case that you need any like orthogonal views, any hints from the angiogram? And I know you said that once you see calcium, that's really a time to stop and think, because now the time is going to be extended, the patient status, the kidney function, the cost, traffic in Jordan. So do you advise those cases to be really done on a staged form, or just go and complete the mission?
Okay, that's an excellent question. Especially في الأردن we عندنا كتير تحديات و challenges إنه what to do. So my advice, and I always use this advice, walking away from a lesion is much better than engagement with a lesion that will turn into a disaster. I remember in my all years, I have never regretted walking away from the lesion, and I have many regrets for approaching a lesion that I should not have touched it. I was not ready enough for it. So definitely, number one, use all the tools that you have to estimate the calcium. Number two, if you are having tools for IBUS, please use them. Number three, if you have Rota available, if you are في الصحة أو في الخدمات ومع الناس زملائنا الخدمات, and you have the Rota, use it. The cost is out of the equation. Please use it. Final, the most important I advise, whatever you do, engage or don't engage, if you do not expand the lesion with the balloon, do not put a stent. Again, if you do not expand the lesion, do not put a stent. Leave it for another time. Approaching a lesion without a balloon, much easier than approaching a lesion with under expanded stent. This is the gold advice.
Thank you. The name of the medicine is Atasigwat.
Working off the lesion أحسن جواب هذا. Working out of the lesion فكك من السلافي. تفضل.
ممكن نسمع؟
هذا مش شغال. صباح الخير. Good morning. يعني excellent job. يعني these are heroic cases. So thank you Fadi and thanks Raed. First I have a comment. يعني the poor man, the old days when we have calcific lesions, we don't have the Rota, and we don't have the IVL, we put a wire or two wires, then a cutting balloon through the guide, and let the wires be like a shaving for the calcium, and sometimes it does work. So for those who don't have these modalities. My question to Fadi first, and then to Raed. Fadi, your case was a typical case of failure of grafts. It was done in 2018, but no lima. Why not to offer that patient, especially with the mitral regurg, a bypass surgery done properly? That's my question to you. And the question to Raed after that, so I can sit myself. Raed, do you think that heroic thing you did, which is going behind the plaque, is a must IVUS case? Or can you do it blindly? Because this is something not to be done by beginners for sure. Thank you.
That's an excellent question. I don't have a good answer why the lima was not used in 2018. Unfortunately, till now, we see some of these cases that lima is not used. And if we have somebody from the surgical colleagues can comment on that, definitely there are different inputs at the decision in 2018. Lima is the standard of care, but definitely there were some reasons at that time. Second, a redo per surgery definitely has a higher risk for that. The last point, it was very difficult to convince the patient to do a diagnostic cath only. They were so scared because they were told, don't do anything. This is the final destination for you. So imagine how to convince them to do a redo surgery. So.
سؤال فادي مرحبا كيفك؟ السؤال لك لو سمحت.
الحمد لله على السلامة.
الله يسلمك الله يرضى عليك حبيبي.
بس.
نعم.
For using IBUS, actually in my case, I never regret of using intravascular imaging in any lesion, whatever you say it, because really what we see in the angio is sometimes, or most of the time, is different than we see by using any intravascular imaging, which really I really prefer. But in this case, as you can see, it was very difficult to actually go with the wire, very difficult with the low profile balloon. You need struggling to go there. Definitely you don't want your imaging device to stuck inside that lesion, because really you will go in more heroic problems than that you expect. Yes, after crushing the calcium, maybe I use it for sizing, for optimization of my stent as after stenting. But before that, I think there is no extra points that we're going to gain.
فادي سؤالي الفترة الأخيرة بنستعمل سي تي كاردياك سي تي كثير في المرضى اللي عندهم كوروناري ارتري ديزيز. السؤال الآن احنا طبعا في عندنا ايفاس والايفاس داتا للروتابليشن، تعتقد في رقم محدد بيساعدنا في الانديكيشن للروتابليشن في الكالسيوم سكور؟ في أرقام محددة؟
Excellent question. No, I'm not sure about that. But don't forget that the calcium score, obviously, for all the arteries, usually when there is a previous
calcium score ما بس تقدر تقيس شو اسمه؟
هلا هون بصفي النظرة على العين، يعني كيف الواحد بيطبخ على العين، بصير على العين انت تتفرج على الكالسيوم، تشوف الاكستنت سيركمفرنشال تاعته، براجع السي تي بنفسي وبشوف كيف الكالسيوم and you get a sense how bad that calcium it is. And just a quick thing, from my personal limited experience among all of you, with all respect, limited experience لاحظت حتى في الكالسيومات في كالسيوم بتلاقيه طباشيري بس بتلمسه بصير يتكسر، في كالسيوم صواني مهما عملت فيه ولا يمكن يتكسر. And this is just a personal experience. I'm not sure if everybody else have the same experience. في كالسيوم بس ما تلمسه بتلاقيه فتفت، في كالسيوم ثاني شو ما عملت له ما بتكسرش. I don't know how to differentiate between both these types. I'm not sure if any literature available. رائد إذا عندك معلومات.
آخر سؤال دكتور هادي. آخر سؤال.
It's actually not a question.
Just I will answer it. I'll continue. Just to answer. Actually, when we have the calcium, the intravascular imaging, the point of intravascular imaging is very important. Using IVUS or OCT, and to differentiate, is it just a layer or multiple layers, or you have it as a mountain rock? When you have it as a mountain rock, really this is the difficult one that you may not go. But some of them, really as the outer layer of an eggshell. It's just an eggshell. So that one is easy to go. And this is the importance of using intravascular imaging always in calcified lesion.
First, wonderful cases, great teaching, great advancement of intervention in Jordan. But let me make some comments here. One, and I believe in that, severe calcification in the coronary artery is an overrated statement. Why am I saying this? الدكتور سأل سؤال على الCT. الCT you can have a calcium score of 5,000 and still those can crack with simple balloons. It all depends about, as we said, about the calcium and the imaging. Now, the other thing for Dr. Raed, it's a beautiful case which you put up. But going back to the basics of intervention, you cannot diagnose a calcified nodule by angiogram, period. You just can't. Nobody can do it, okay? So putting an angiogram and saying this is a calcium nodule, I'm not quite sure. It's not, I mean, you need an IVUS, you need an OCT to say it's a nodule. Why is this not a nodule to begin with? A nodule is a calcium sitting متجذر جوا بالانتما almost واصل للادفنتيجة. It's not just sitting superficial. It's very hard to go behind it with a wire. It's really very hard. I mean, you're lucky, that's wonderful. So I think imaging in those cases is a must if you can pass the IVUS. The thing which is amazing to me, that a lot of the interventionists, especially the young generation, they're not really patient enough when they see a lot of calcium. And geographically, you cannot judge the severe calcium. It's sometimes really difficult. Where the calcium is it with the heartbeat? You know all of these classifications, but it doesn't tell you a lot. The only thing which can make you plan it correctly is imaging. This is the only thing. That's if you're lucky and the IVUS passes. Why am I saying this? With my due humbleness, I've been doing intervention for the past 35 years in addition to my training. Tell me how many times I went to a calcified lesion and I said, gee, I wish I had the Rota bladder on the table. I'm not exaggerating. It's just maybe once or twice a year. It doesn't happen on a daily basis, but it really needs a lot of patience. It really needs a lot of patience. But wonderful cases, and I learned a lot from you guys. Thank you.
انتهت الجلسة. طيب آخر جواب والله لو سمحت.
Dr. Hadi, it's an excellent statement. And I'm not going to go into the nodules and angiography because there's a lot of debate. I'm not going to go through it. But I'm going to talk about the dilemma that we all have. اللي حكيتها أول شيء إنه هو حيكسر ولا ما حيكسر. But this is my advice since you are experienced and I'm in the middle and we have young generation here. Our job is to be as safe as possible. Unfortunately, as the doctors, and I'm telling here as philosophical discussion rather than anything else, with all respect. The thing here we are talking about, we have as physicians, unfortunately, we have to be right every single time. So, I always tell the patient, my job is to cross the traffic light, الإشارة خضراء، وأتأكد إنه فيش ولا سيارة، وأتأكد إنه فيش أي شيء. بقدر أقطعها والإشارة صفراء وحمراء؟ ممكن. حيصير معي حادث كل مرة؟ لا. But it's the percentage. And all the trials, they are about these 1 to 2% with the p-value of 0.049. Perfect. Let's use that medication. So this thing is about the thousands and thousands of cases. I wish, as you said, I have a crystal ball to put it there and tell if this will crack or not crack. But as you said, the final tool is IVAS. Unfortunately, we are limited with the cost. If we put the cost out of the equation, IVAS will be flying off the shelf in Jordan. Thank you, sir. Yes, I know.
Not forget the patient. If you're dealing with an elderly female, CKD or dialysis, you know that's going to be.
انتهت الجلسة.
انتهت الجلسة.
شكرا للمتحدثين.